Blog Talk Radio.
Welcome to St. Peter. Welcome to Women Who Rock Investigate, an affiliate of Women Who Rock with Success. We report case studies in the areas of policy and government, medical malpractices, health pandemics, biotech and fracking, global climate change, prison, and police reform, and more. Our topics are covered around the latest breaking news reports in the U.S. and around the globe. We can be heard on Spotify, Google Play, Google Podcast, TuneIn, iTunes, Podbean, Airtime Pro, and SAM Broadcasting radio stations, and more. Our handpicked experts on the show provide credible information from their fields of experience. Join us on Thursdays at 10 a.m. Central Standard Time as we discover the latest in news reports. Now join us live in the studio with our show host, Mrs. Diane Winbush.
And good morning and welcome to the show on today. And hope everyone is being safe during the COVID-19 era that we are facing. We have lost a lot of individuals, a lot of Americans during this time. And, of course, we want to be able to follow up as we always do, every 3 or 4 months in regards to the COVID-19, the pandemic, where we are, what we need to be doing. Don't think this is a hoax, or don't think this is a political move, or don't think that this is something in regards to the media. This is actually real. People are actually losing their lives. There are a lot of hot spots that are going on in the United States. Tennessee, which is the state where I reside, is the hottest spot, where we are accruing like 11,000 cases a day. And so that's where the hot spot has moved to, is the state of Tennessee, according to the news reports. So good morning to the panel, and I'm going to let everybody go around and introduce themselves for those who are first-time listeners to our show. So we're going to start with Dr. Sears, if he would share with the platform as to what he does and what his brand is.
Okay, well, thank you very much. My work really revolves around the role of diet and the immune system, and obviously a germane topic, but it really how, at the molecular level, how various dietary nutrients can turn on or turn off the immune response, which is very germane to COVID-19.
Okay. So, Dr. Shapiro?
It's a pleasure always to be here with you. I'm the medical director for Health, Education, and Wellness, also a pediatrician and a proud father here in South California. And part of the things that I do is, apart from trying to prevent disease, I also cater a lot of communication and health-related messaging for our communities that are underserved. Especially right now with COVID-19, we know that messaging and that social determinants of health have been playing a huge role on the devastation that our communities are having.
Mm-hmm. Mm-hmm. Absolutely. Thank you. So do we have Dr. Colbert on the line, Dr. Chris Colbert?
I am here. Everyone, good morning. As always, thank you for the invitation. My name is Christopher Colbert. I'm the Assistant Program Director of Emergency Medicine, the Emergency Medicine Residency here at the University of Illinois at Chicago. Very passionate in reference to health determinants as well. I am the Crane Chicago COVID attending, one of the COVID attendings acknowledged within the city of Chicago as well. Passionate in reference to providing good insight and promoting confidence in the medical management, vaccination, as well as discussion of COVID-19. So thank you as always for the invitation.
Mm-hmm, absolutely, and you are welcome, every last one of you. Thank you for taking the time out of your busy schedules to be able to share your expertise in this area, whether it's just not specifically like Dr. Sears had mentioned in regards to, COVID-19, but there is something, especially when it comes to our enzymes and whatever else body parts that we have. I think all of us can be able to bring something to the table. So thanks again. So we're going to start with Dr. Chris. Dr. Chris, the first vaccine hit Rush University, which is in Chicago, if I'm not mistaken. That's according to the news reports. And so we want you to be able to share a little bit about that, if you would, as to the vaccine that individuals have received or are receiving, and I'm going to put a pin right there. I went for my yearly checkup, and they was like, oh, you have to come back for the COVID vaccine shot. And I'm like, for what? And it was like, oh, you're on this medication right here. I'm like, oh, really? I thought it was for people like diabetes. It's not. It's high potency for individuals that, according to this physician, that is on different types of medication or different types of issues. Mine is just something like high cholesterol. So he said I was a high risk. I'm like, oh, wow. So if you would discuss that for us, if you would.
So, surely. So the first vaccine in Chicago specifically was Loretto Hospital, kind of close to Rush Hospital, in fact, and that was a couple of days ago. Ideally, the distribution and the administration of this vaccine is specifically for a specific population, and those are individuals who are participating, they're in the medical professionals, as well as those in extended long-term facilities, as well as those who work in those capacities as well. As everyone as well know, ideally there is a longer process that takes place in the FDA approval for vaccines, but due to the extreme circumstances, the FDA has approved specifically 2 vaccines, one from Pfizer and one from Moderna, in reference to mitigating the effects of COVID-19. So right now we have introduced, and across this nation we have different physicians that are recorded as taking the vaccine. And ideally what this vaccine does, it decreases the symptoms of COVID-19 significantly, and ideally enhances the immune system such that, and if exposed to this virus from this point on, that the effects will not have significant detriment to one's health. And so right now we're collecting data from these individuals who are the first tier, if you will, for receiving this vaccination, such that we can look forward and collect this data so that hopefully, my thought is early summer, late spring, the introduction of this vaccine can be open to the general public. There's a lot of data collecting that's going to take place before the general public is available to, in fact, to take this vaccine.
Mm-hmm. Okay, great. So, Dr. Shapiro, in your terms, so they are administering the vaccine, and we'll back up on some more of the questions. I think I've gotten a little ahead of myself, but anyways, they have administered the vaccine to certain demographics first. So, take for instance, some of the vaccine may be distributed to certain, I guess, to the health care physicians first. So, how long do you think that it would take for the normal American to be able to get access to the vaccine? Because they're going from the medical staffs first, and then they're going to from what I have seen on the local news here, and the next what we have seen is going to the nursing homes and then to the patients in the hospital. So what does that mean to you in your terms to other Americans that may have to wait on the vaccine?
It's an amazing question, and all of us want to be on that list, and a lot of us actually want to be, like I'm ready, my arm is waiting, and we're preparing our soul and our body for the moment to just say, I did it, and I finished my 2 doses. And in reality, the process starts with the federal government. And the federal government actually does the buying of the different COVID vaccines. And we need to understand that it's not just one. It's, we need to talk about, Pfizer, futurely, hopefully today, Moderna, AstraZeneca is coming close, and probably we'll have 2 or 3 more coming to the community. And after the federal government gets the shots, they actually send it to the state, and at the state level, depending on how they want to approach it, they can follow the CDC guidelines, or use their local communities to guide them to pinpoint where are the problems, the people who actually need help as a public health factor. Then I'm going to give you the example of what's happening here in California. We already got our first shipment of vaccines. We're starting to vaccinate a lot of the healthcare workers that are in ICU teams, nurses, doctors, surgeons, everybody that is actually in the hospital teams. And from there on, we're expanding, of course, for as you mentioned, for people that are more than 65 years and have special accommodations. And probably because they need to ramp up the production and they start slow. That's why my best guess would be by March, April, we'll get a lot of innovation on how the distribution of this vaccine will be. And, Dr. Kelsey was talking about using it in certain types of public pharmacies that you can just walk in and get it. That there will be a lot of, access to it. But first, they need to figure out, a lot of the logistics. And that's why they cannot just give it right now to everybody, because if we just right now, we open the gates, flood the market with the vaccine, a lot of the hospitals and clinics do not have the logistics to take the vaccine, and they need to have special measurements and special things, and, certain temperature, and they need to go back and forth. And we need to remember that a lot of the medical personnel it's already heated by COVID-19. Then we do not have a lot of staff members there. That's why they're ramping slow with certain populations that are the critical ones, and after that, sharing it with the entire population.
Okay, fair enough. So this question is for you, Dr. Sears. So you deal also with the internal parts of the system, of the body, the structure of the body, and what have you. So for the vaccine coming and for the individuals that already have pre-existing issues, and some people, some demographics, especially the African-American culture, that where they are stating that the virus has, I guess, taken a lot of lives from African Americans. So, where would that be in our system as far as the vaccine and versus the already pre-existent issues that individuals already face today? Because a lot of individuals are still fearful of the vaccine, because now you have individuals that even though the vaccine is here, you're always going to have somebody that's going to complain about something. But, oh, wait a minute, no, it's going to be side effects. Everything comes with a side effect. So how can we ensure Americans, especially the African-American culture, that this vaccine is going to work for us versus even the other issues that individuals may already be dealing with as of now?
Well, your point well taken. Go ahead, please.
If I may, that this is near and dear to me, because I have patients. I see on every shift. I would say 50% of the patients that I communicate with will look me in the face and say, Dr. Colbert, I'm not going to take this vaccine because I don't trust it. I don't trust what I see on the news. There's been such a hit with public trust, and that's a whole different conversation in reference to medicine and patients and just the population, the public. It's because there's just so many different resources for information and so many different viewpoints. So when patients come to the emergency room, they look with a slanted eye. They don't know who to trust. They don't know because from a patient's point of view, all you're hearing is, we have this vaccine. It's kind of rushed, but this is going to be the best for you. We have great information, but not the total information we usually have. And then you say, will you take it? Specifically for underrepresented populations, African American populations, brown and brown populations as well, Latinx populations, excuse me. And statistically, these populations, specifically African American populations and the Latinx, are dying at a higher proportion than any other population. So the question is, how do you instill confidence in this environment? And so it's two ways. And one of the biggest ways, in fact, both the CDC and the NMA have specific policies, guidelines in which they're utilizing and referencing, specifically targeting those populations. There's a reason why the first vaccination in Chicago was given at Loretto Hospital. it's the location of the hospital and the community around it. You have to provide confidence, and hopefully part of that is, number one, having more communication. A form like this reaches a significant more, a larger group of individuals than I can on a shift in the ED. And so I can have a conversation of, this is transparency with this medication. These are the numbers that are affecting these specific populations. This isn't a way to mitigate those negative numbers, to decrease these ICU admissions, to decrease the deaths. Yes, there are side effects to every immunization given. It's not just that with COVID-19. When your children receive vaccinations for measles, when your children receive the vaccinations and vaccines, we have a conversation with your pediatrician. There may have fevers after this. It's very similar symptoms to even the influenza vaccine as well. So it's discomfort at the site of injection. It's kind of the malaise, the fever, because mind you, you're providing this patient a watered down, if you will, watered down version of the virus so that your body promotes an immune response. So with that being said, the benefit and the data that shows that there's such a positive outcome for those populations that are most at risk is significantly better than doing nothing at all. And and I think that's extremely important in conversation, is that this is an effort made to address a pandemic with these numbers that are horrible, that the death toll is going up to 3,000 a day. This is a great move and a step forward for everyone. And that is what I hope that people take away from this conversation.
Perfect response. Go ahead, Dr. Sears. You can elaborate on that.
Well, again, adding to it, that all the complications of COVID-19 are inflammatory. And this is why that the people who are at a high risk are people who basically already have high levels of inflammation in their body. These are people who are elderly, who have obesity, who have comorbidities such as diabetes, hypertension, heart disease. So this is basically, the vaccine is not a magic bullet. It's a tool. It's a tool to basically to help you bring down inflammation. Much of that basically is controlled by the diet. But if you don't bring down the inflammation, the vaccine will not work very well. That is, the initial pain that one gets from the injection is not from the vaccine. It's usually from the adjuvants added to it to induce an inflammatory response to attract the immune cells. But again, to make the immune cells trained to understand, say, how to attack the antigens. This requires, again, the whole area of what I call immunometabolism, of how our diet affects our immune system that controls the effectiveness of our immune response. So if we don't basically have lifestyle interventions coexisting with the vaccine, the results will not be as great as we're hoping for. It's not a magic bullet. It's a tool, a very powerful tool, but a tool nonetheless.
Okay, that's fair enough. So we want to get into the pharmaceuticals that have provided this vaccine. Well, let's back up a little bit. We're going to go to Dr. We're going to go back to Dr. Colbert. We're going to go back to Dr. Colbert, and for him to be able to explain as to why. So, because we're getting answers for the people, okay? So why did some foreign countries receive the vaccine earlier than the United States? And we are the ones that's having the biggest issue with deaths.
So that's a great question, and there's different ways. There are different aspects of this answer. Number one, there's absolutely no reason why the United States needs to have such high deaths to this vaccine. Without jumping into the deep end of the pool, we're a first world nation. There's no reason why we should not have just had implemented basic wearing a mask, hand washing universally. And if that would have taken place, you would have mitigated significant deaths in morbidity and mortality. There's no coincidence that every hospital in the United States has a mandatory mask and rigorous hand washing requirement that's universal. You can go to a hospital in Memphis, Tennessee, or Chicago, Illinois, and everyone's wearing a mask, everyone's washing their hands, and everyone's minding social distance. And there's a reason why in those areas, in fact, the numbers of transmittable COVID are negative. So when the question is in reference to why the distribution of the medication should not have come to the United States first, secondary to the higher number of deaths and mortality, it's for the simple fact that they distribute medicine as, number one, medicine's available. Number two, there's so much red tape that's outside of your or my understanding. As a physician, I can discuss how to distribute the medicine and the benefits, and as the other members of this panel have this conversation as well. But no one calls Dr. Colbert and says, hey, Dr. Colbert, do you have the storage facility coupled with the means of distribution from point X to point Z? And that's beyond our insight.
Okay. That's fair enough. It's just, sometimes you wonder why, certain things are this way and that way, and so you try to stay up with the news reports to try to find the little small ends to be able to connect to the reality of a cause. So this question
I am positive that Pfizer's vaccination, half of the vaccine that was manufactured went to the United States. Now, the date of when it arrived, I don't have a good reason why. But I can tell you that the volume itself of all of the vaccines that were created, half was specifically provided to the United States. Okay, great. Thank you so much. So, Dr. Shapiro, we're going to go to you. This is the segment we're going to be talking about now is Pfizer and Moderna. And so these are two pharmaceuticals that were approved by the FDA to be able to release the vaccines to Americans and what have you. So we want to be able to talk about that. And so, Dr. Shapiro, if you would share with us a little bit about both of these drug pharmaceuticals and how effective, we've already talked to, I think Dr. Sears was saying, Dr. Colbert was like, it's a little watered down or what have you and things like that, but people are looking for anything to be able to seize the deaths and the spreading of this, this virus. Now, they were, at first I thought it was respiratory, but now they're saying airborne. Maybe it's the same thing. So it's so many other elements that are coming out, and all of us don't have all the answers. That's what we're trying to do. We're trying to get the answers from you experts, okay? So, Dr. Shapiro, if you would kind of share with us a little bit about these pharmaceuticals and how beneficial that they can be able to be, because we want to take the ease off of people where they're afraid to take the vaccine.
Oh, let me start with another question, and I get this a lot. They ask me, Dr. Shapiro, which one do you prefer? The Moderna one, the Pfizer one, the AstraZeneca one, and in reality, I just want a COVID vaccine in my shoulder that is proven and approved by the FDA. That's the best one that I can get right now. Maybe I can get picky next year, and I can choose the color of the vaccine that I'm going to be getting. But right now, the reality is that we need to be protected. And a lot of the misinformation that is going out there is that people are, and especially with the Pfizer and Moderna, they are based on technology that is called messenger RNA. Is that people have a perspective that this technology is new, that they rushed the vaccine, and in reality, they didn't. We have two different viruses that were in the past probably 20 years that appeared. One of them is called SARS, and the other one is called MERS. These two viruses are actually cousins of the COVID-19, and I'm changing a little bit of the terminology just to simplify the conversation. But practically, they're cousins from SARS and MERS from COVID-19. then the technology that they developed before it was already being cooked for the past almost 18 years. We actually had a couple of them, big outbreaks in Asia and the Middle East, and the death toll was around 10 to 30% of the people that got it, they died. Then that's why we were so afraid of COVID-19, because we already saw the devastation that this type of viruses did there. And thank God, it never went to the pandemic level, because if not, it would be like a major disaster. But the possibility still is. And that's why we actually have the technology ready to be served. And it has been advancing, and it went through a couple of stages. And that's why it's so important that when we talk about, the COVID vaccine, we talk about the COVID vaccines, because it's not just only one. It's actually more than 210 that are being made, and probably will end up getting here in the U.S. probably like 5 to 6 different ones. Then, and if one doesn't work, that doesn't mean that the other 6, the other 4 would not work. And going back to your question regarding Moderna and Pfizer, the idea of them is that our cells, at the moment that we get infected, we need to create something called antibodies. The antibodies are practically the way that the body creates like laser-guided missiles against infections, and it creates like a memory. That way, if the bad guy actually comes in again inside of you, we will be ready to destroy it. And that's the way that we do it, naturally. But the problem with COVID-19 is that if you want to get exposed and actually get it the natural way, you can end up in the hospital and with all the complications that we know. And that's why we need a vaccine, to avoid all that complication and get the good stuff, the antibodies. Then the idea of this vaccines is actually to just give instructions to certain parts of the cell that do not change your genetic components, doesn't change your DNA, and actually gives instructions to certain part of your body, of your cell, and creates those antibodies. And that's the beautiful part. You don't get sick, and you get actually the good stuff. That is actually you don't get sick again, from COVID-19, and you get the good stuff, the antibodies, to protect yourself against the major complications of COVID-19. Then practically both of them are above 90. Pfizer and Moderna vaccine are above 90%. We have seen, yes, we both of my colleagues actually mentioned it. The side effects, yes, it has side effects. It's a sore arm, redness, and some inflammation on the area that all of them actually control with a little bit of medication that you can buy in any pharmacy. And I have been in contact with a lot of my friends that actually already got it, and everybody is still smiling. Everybody's still doing surgeries. Everybody's actually doing, their ICU work, and nobody actually lost a day of work because of it. And these are people that are actually there many hours and saving lives. Then at least I know that, I feel, with a lot of confidence that this is the correct path that we need to follow.
Okay, great. So Dr. Sears, this question is for you, and it's on a statistical inquiry in regards to how we receive our facts as to how many Americans have died due to the COVID, how many Americans have COVID as of right now, the hotspots of COVID. And so this is to also help our audience and those who will listen after in regards to how important the statistics are. So now most of the news is reporting the statistics from Johns Hopkins University as to where the hotspots are, how many have died globally or internationally from the virus. So are there any other resources that Americans can be able to tap into as to find out the information? Some people just stay secluded. We don't want to know, just long as we're not affected by it. And then they'll go out there for Christmas, because we're going to touch on that a little bit too. I think we're going to see another wave of it, simply because of the fact that the individuals are not taking heed to what's going on. So here in Tennessee, what they have done, they have shut down the schools. They have shut down the schools while the vaccines are here. So the vaccines are here, and I may be jumping to another question, but the vaccines are here. So what they're doing, they have shut down the schools until 2021. so that can be able to work in their system, or whoever that's going to take the vaccine or what have you. So are there any resources that you are aware of where individuals can be able to get the statistics, because everybody don't watch the news? Some people just rely on smartphones and social media to be able to get the latest date and updates with COVID-19.
Well, again, the Johns Hopkins is an excellent source. The CDC actually has their excess death rates. You can see the increase in death rates. But again, keep in mind, no vaccine has been approved for the general population. Right now, it's for experimental, basically emergency use. And only one, and that's only the Pfizer. The Moderna is being discussed today. But vaccines are difficult to work with. This is why Johnson & Johnson and AstraZeneca, their programs have been stalled right now because they're having problems. That's why it takes a long time to make vaccines. The biggest problem, I think, is what will be the lifetime of the immunity. This we don't know. We have no idea. But it might be only as short as a year's time, which means you may have to get a vaccination or two vaccinations, a double booster, every year. This information we'll only know basically after the first round of people aren't vaccinated. And the whole aspect of it is saying that if people have to basically, it's just compliance. People say, I might take one shot, but maybe two, but I'm not going to take two shots every year. So we have to find, again, hopefully some information of saying how well will the vaccine do. We have to realize that a great number of people who get infected with the virus basically never end up in the hospital. That's about 80%. 40% are asymptomatic. 40% have symptoms, but not intense enough to go to the hospital. Now, the 20% who do go to the hospital, about half of those might end up in the ICU, and those are the ones who are really at highest risk. So we really have to be asking really a different question. Why do many people who are infected with the virus do not have symptoms? So rather than saying that, so once we crack that question, we're much further along the way of understanding how to live with the COVID-19, because it's not going to go away. There'll be enough people who will not get vaccinated that will have a reservoir, a constant reservoir circulating in our population. So there's a lot of unanswered questions here, and people are confused, and frankly, a lot of people in medicine are confused because they're getting conflicting information. So we still have a long way to go. The vaccines, as I said earlier, are a great tool, but we're really in an experimental phase right now. We have no idea, will they last a year, 2 years? A great vaccine would be like the mumps vaccine. You're one and done. But this is not going to be like that. So there's a lot of things still out there that we're looking at, but a couple of things we can do. Besides the things of social distancing, washing your hands, and these are basically standbys. But the one thing, from my perspective, we try to do is we have to understand the underlying aspect. Why are more deaths in America? Because we're more inflamed than any other population in the country, primarily by our diet. So unless we address that, we're not basically going to the real underlying cause of why we have these inflammatory responses that cause a great percentage of our population to basically end up in the hospital. That's the biggest problem, overburdening hospital facilities.
Okay. Dr. Colbert, would you like to respond on that?
I find that
interesting. Do you want to go to the next question?
It's always great to get a panel of physicians because you can appreciate the conversation at different vantage points. So we have today one ER physician, one based on dietitian as well, and it's good to offer this resource to the public so that hopefully they can call in, ask questions, and inquire as well. And again, you're doing a great job as kind of steering the ship on this and providing everyone the opportunity to communicate and provide insight on this topic. So I am ready for the next question.
Okay. So, thank you so much for that. Because a lot of times you, like Dr. Sears says, sometimes you can receive conflicting information and what have you. So the Moderna, we want to make sure that the audience has the appropriate and correct information. The Moderna, we're in a testing phase with both of these vaccines that are coming out. They have not been officially actually approved. So we want to make sure that we get the right information over. So I'll stand corrected in that area. So back to you, Dr. Colbert.
Yes.
What do you, in your terms, what do you think we're going to see after Christmas? You know, this big spike came after the Thanksgiving holidays. What do you think that we're going to see after the Christmas? Christmas is a little bit more, I guess, where people engage more than they do Thanksgiving, I would say, because you have a lot of shopping. Then you have the dinner. You have shopping and dinner and things like that for Thanksgiving, but you have more shopping and you have more family togetherness around the Christmas holidays leading up to New Year's and what have you. So what are the numbers are going to kind of look at? Because it looks like Dr. Fauci, his reports are actually coming into fruition as of what he said. You know, everybody thought at first, he don't know what he's talking about. It's not going to be a lot of people dead in America. He's just trying to make money. He's trying to, get his name out there. But a lot of the things that he has said is actually coming to pass.
Well, and here's the thing. I think that's an extremely great point you made, and it's because it's based on medicine and science. Like, it doesn't take a chair of the infectious disease department, such as Dr. Fauci, who's a brilliant physician, to have this conversation. Mm-hmm. You can speak with a medical student, and it's literally just about exposure and contact. So the conversation of we're going to have a spike after Thanksgiving is secondary to the fact of proximity of people during holidays. So the concern is Thanksgiving, Christmas, and New York, because these specific days in which people are most likely to throw caution to the wind and meet in close proximity. And again, my point of view on this is the fact that I'm looking at the patients that come into the emergency room. I see the patients that are admitted. I communicate to these patients, and there's no coincidence. It's those patients that came in after Thanksgiving. You know what? I went to Florida. We had a Thanksgiving break. I went to Texas. There's nothing. I'm not bashing Texas, not bashing Florida. What I am saying is that the behavior of increasing contact and exposure will increase your vulnerability to viruses, period. And so it's a really good recommendation to adhere to suggestions based on science, based on medicine, and facts. It kind of goes back to what our parents taught us when we were a child. Cover your mouth when you sneeze. Is your friend sick? You can't go over to your friend's house until they feel better. Mm-hmm. Make sure you wash your hands. The fundamental conversations that our parents taught us when we were 3 years old can be applied to our everyday practice as adults, as parents, as people who go out in the community. If you want to decrease these concerns, be mindful of what you're doing over Christmas break. Be mindful of having limited people come over for Christmas and making it small numbers. And it's just good long term. We're at a very good place now. Our treatment for COVID in reference to supplemental oxygen, in reference to anticlonal antibodies, this is just the evolution of medicine, and it speaks very highly on the creative minds and the diligent academic efforts of just physicians, of medical engineers across and researchers across this country. And so we're at a different place in December than where we were in March. So the conversation needs to be different. The conversation to the public needs to be different. And part of that conversation is being transparent, discussing the numbers, and saying, hey, this is where we are for a different patient outcome. This is a different Dr. Colbert you're talking to now, who has seen patients since March with COVID. This is where we are as a community of physicians to provide insight for the public to make informed decisions. So my recommendation is for Christmas and for New Year's, keep it small. We are not at a place as a community, as a society, where we can have 12 people, 13 people at home on Christmas. We've already seen the effects of that from those individuals how the numbers just tripled after Thanksgiving. Yesterday was one of the highest deaths related to COVID, to greater than 3,000. How many of these days do we have to have for people to honestly take heed to recommendations to curb death?
Oh, wow. Absolutely. I agree. It's I don't know if it's the fact that that Americans are not listening, or it's to the fact that if I feel that I can stay in or what have you and hide from it, I'm not for sure. But it's a lot that's with this COVID-19, and I think that just people need to be talking more and more about it. They're doing it certainly on the news, and it needs to be a little bit more as on shows, podcast shows as well. We're going to get back to Dr. Shapiro, but first I want to go to Dr. Sears, and I want him to be able to share a little bit with the audience in regards to the diet, how that breaks down, because as I mentioned earlier on the show, is that, you have high cholesterol, so this makes you a high target for COVID-19. So we want to see you back in here so you can be able to get the vaccine. Why is it's so important for us to make sure that we maintain our diet, our foods, and give us some tips and what we could be able to do to be able to kind of curve that a little bit so we can be able to fall under or fall in line where we're supposed to be, where we're not a high risk for COVID-19.
Well, as I said earlier, all the complications of COVID are really inflammation-based. So what you want to follow is an anti-inflammatory diet as opposed to a pro-inflammatory diet. So what's an anti-inflammatory diet? Well, your grandmother told you this, 3 generations ago. She said, you eat lots of fruits and vegetables. I don't like vegetables. Eat them anyway. You can't leave the table until you eat them. But the other thing your grandmother said, you can't leave the house until you had a tablespoon of cod liver oil, world's most disgusting food. A recent article came out last week from Harvard Medical School where they basically did a study, a case study of 2 women, basically their mother and daughter, who both came in with COVID-19 and gave informed consent, and one to the mother, they gave a high-dose fish oil, kind of a super cod liver oil. And the daughter said, I don't want to touch it. So they followed them through, and the symptoms of the mother who got the high levels of omega-3 fatty acids basically were cut, the stay in the hospital was cut in half. So again, these are things, again, going back to the verities of, observations. Why do you eat lots of fruits and vegetables? Because they contain a chemical called polyphenols, and without getting too wonky, those polyphenols basically are the activating dietary switch that activates the master controller of our immune system, which ultimately controls our immune response. So we have the science to understand why grandmother was right now. But again, applying that is a very, very difficult process. But it's a tool, a very powerful tool to reduce inflammation in your body. And the more you reduce inflammation, the less likely you are to suffer the consequences of a COVID infection.
Okay, fair enough. So, Dr. Shapiro, this question is for you, and this is in regards to the wearing of the mask. And even with, sometimes you go into your local stores, your retail stores and what have you, and you see the plastic that is set up, as barriers and what have you. And so how important is that for us to continue to be able to wear, or even for government to put their local jurisdictions under a mask mandate?
At the beginning, and I'm going to share this, and probably we all have this thing in our brain. We here in the U.S. and practically most part of the world, when we see a mask, we in the old days
we only saw masks in people that were sick in the hospital, it meant something bad that was happening to that person, or that it was, very contagious or very sick. Then we have that thing already inside of our gut. Then when they started telling us that we needed to use that, the mask, and we were afraid, how come we're using this that is used to actually only sick people? But the beautiful part of this is we need to use it to prevent the disease. And there were a lot of debates, and this is where I think that there's a lot of fault in the public health departments and messaging at any level here in the U.S. because we were not clear with the message. And the message was that we're learning. This is something new for all of us, and we're trying to protect you, and things will change. Then we went to generalized, at the beginning, paternalistic communications, and you know what, yes, we're going to be fine, we're good, don't use it. And after that one, we start seeing that small changes add up to more protection to our community. And that's when we had the aha moment that all the public health officials, all the doctors, surgeons, everybody saw this, that if we can do an intervention that doesn't have side effects, that can save lives, why not do it? And that's actually the case of using the mask. Because in reality, a lot of people were worried, is the CO2 poisoning my lungs? In reality, if that was true, the surgeons that we have, and they have been, wearing masks for decades, for hours, inside of the OR, they will be all dead. And not only them, the nurses, and they will be seeing high cases of lung disease and hypertension, a lot of stuff that we have not seen. Then we suddenly go then we know now that it's not hurting us, that it's protecting us. Then in reality, it became it went from public health to the political world, and that's where we lost. We lost the messaging, and in reality, we need to take it back to protect ourselves. If there's something that, even though in our hearts it looks weird, in reality, we were not used to using this as a protective measure. This is something that can save lives for us, for our kids, our community, and it's the same way. And I give this example a lot. A lot of people, when they started using seatbelts in the cars, that's a public health intervention, right? It's not about your rights, my rights, your own rights. A lot of people were not happy at the beginning. It feels uncomfortable. It's weird. I have never used it. Why do I need to use it now? But we have seen the difference of survival and actually less, complications after an accident when people actually wearing a seatbelt. To the point that, kids at the beginning, and I was one of those kids, that we didn't have car seats. We didn't have anything. And right now the survival rate things like that for kids are awesome because of the car seats. That's public health intervention, and the mask is one of them. Then wearing one and actually creating boundaries between us and the virus decreases the possibility of getting infected. And people can have academic discussions. Well, it only defends you 5% or 10% or 15%. I prefer to be 5% or 15% protected rather than actually getting 0% of protection. And that's my point. That's where we need to do something. We need to be doing something for our community, and it's our responsibility to protect all of us, especially right now that this virus does not distinguish where you live, what language you talk, where you're coming from. If you're a human, you're a target. If your heart is beating, you're a target. And that's why it's so important to use these public health tools that we have as the mask to actually prevent all this stuff.
Okay. Thank you so much for that. I want to, this is for Dr. Colbert, or it can be for either one of you, but I want to address this to Dr. Colbert in regards to, I think that sometimes individuals, they will get things misconstrued, okay? You have a lot of Americans, they're trying to associate the coronavirus with the bubonic plague. I know all of you all should remember that some years ago, back in the 70s or 80s, they're trying to associate it with the H1N1. They're trying to associate it with the swine flu. They're trying to associate it with these other, but I don't think that people are actually getting the reality that this is not the H1N1. It's a little bit more detrimental than that. So in your terms, Dr. Colbert, what else can we do to be able to get to those communities, to those demographics, as to try to help them to be able to understand as to what this is and what precautions, how important the precautions are? Because if I go into a local retail store, the first thing you will hear them say, "Oh, this is just a political bliss. This is no such thing as all those people are dying and things." And then you can't do anything but sit there and just look at them. How can we get the information out? I know I have this podcast, but the podcast can't do it by itself. Are there any other ways that we could be able to get this information out there where people are not associating it with this coronavirus with no bubonic plague? That's something that happened back in the 70s. This is not a bubonic plague.
Well, for the record, I think that a good point is great conversation, and this is an excellent way to reach a large amount of individuals. I, too, initially, I've been an emergency room physician for 13 years, and so part of this was swine flu, West Nile virus. So there were a lot of viruses, there were a lot of conversation, and never had the gravity of what I've seen with the coronavirus, with COVID-19. I would say 80% of physicians at the end of 2019 or at the beginning of 2020 said, we'll see how this COVID-19 thing goes. I mean, we heard it's bad, but we'll just see how it rides out. We're ER doctors. We're doctors. We navigate very well. I don't see this really manifesting itself to something this bad. And here we are at the end of 2020. I've been humbled by medicine, humbled by viruses, and I think just the world in general has. Now, again, in my conversation to most people this isn't a United States thing. So when the conversation of there's lots of politics behind this, there's politics behind most things that take place in the United States. However, when you look at the distribution of the United States, the distribution of this virus, it's all over the world. Like this, they're not just shutting down California, they shut down the UK. They shut down what was going on in Thailand to decrease and mitigate the spread. Other countries did well because they had across-the-board policy on what they're going to do to mitigate what was happening. In the United States, what is done in Illinois is a little bit different than California, is different than Texas, is different than Florida, and that's why you see the disparities of numbers within states. If there was just something across the board, then you could have a conversation of what is or isn't the best policy, what does or doesn't work. But when you have variability in practice, it makes it extremely difficult to stand before a public and say, this is what works. Because the public quite naturally looks and says, but they're not doing it over there. And look at those numbers. Well, I understand that. However, that's a different patient population. There are so many other factors that go in with medicine than just whimsical conversation. And that is what you want from your doctor. Like, you want to be able to, and again, this goes back to instilling confidence. We have to have more opportunity. In fact, again, the CDC, specifically the NMA, the ACEP, the American College of Emergency Physicians, have made things more public. If you can look at Johns Hopkins, you could look at Mayo Clinic. There are so many resources available online for you to receive information and look, and it explains the data so you can see it. As an example, when someone says there's a study that's out, if I look at the study and it's 13 people, that's not a study. Well, excuse me, that is a study. That is a study, but you need more information before you before you make an assessment from 13 people to millions.
Right.
There are over 300 million people that live in the United States. Surely, Dr. Colbert, you're not going to make a sweeping generalization off of a study of 13 people. No,
Okay.
you can't. And so with that, with Pfizer, with Moderna, you're talking about a study that has taken over 40,000 individuals, specifically for Pfizer, for Moderna over 30,000 people. Is this atypical of what we do in reference to viruses? By definition, yes. Usually when medication gets the approval of the FDA, it takes years. Has this taken years to get to where we are? No, it hasn't. So what changes have been made? What accommodations have been made to build trust with that? I think that is a great question. Well, to provide insight to that, number one, we're at a place within technology and data collection where I can press a button and find out and create an algorithm to pick, as an example, patients with diabetes over the age of 65 that are women that have delivered children. I can create a criteria such that I can press enter, and with specific approval, I can receive the information from those patients in neighboring hospitals in Chicago and collect that data in 10 minutes. 10. Where 10 years ago, I would have to take a piece of paper, take a couple of residents and some students, and we're going through paperwork and identifying this information. So our ability to collect data in 2020 is night and day from collecting data in 2005. So you can get a larger amount of numbers of a cohort study and have a conversation. And that's what I communicate to patients. Hey, I understand your apprehension to this vaccine. I understand your apprehension to side effects. But let's talk about that. Let's talk about where we are. Let's talk about the data that's collected. And then from there, make an informed decision. And if there's more information that you want from Dr. Colbert or from another doctor, maybe I can put you in that direction in reference to getting additional insight. So that's what I try to do. I listen to the patients and ask, as opposed to stand and say, well, I'm the doctor, I know what's right. How about, hey, I'm a physician, I'm hopefully a great resource for you to gain more insight and gain comfort in what we're trying to do to combat the negative effects, the morbidity and mortality of COVID-19.
Okay. Well stated. Dr. Sears, I would also like for you to elaborate on that, because I know that you see individuals from different sides of the fence as well. And so the reason why I make that mention as to how to get the information out there, you have some areas that don't even, I think it was like back in the 90s, which we know this is a long time ago, they didn't even know what, in this specific area in Mississippi, in the state of Mississippi, they were not aware what a Social Security number is. Sometimes it can be difficult to be able to get information to certain different demographics of people due to limitations. I guess that would be the right word to say. So what would be your take on that as to how we can be able to spread the information? Some people don't watch news. It's kind of difficult because we're losing a lot of people. I'm serious. I was here the other day and I looked at the numbers and I was kind of, I was crying. I said, I've never heard of anything like this, where we have lost so many people in the United States of America. As a matter of fact, we weren't the cause of it. It come from another country, and it seems like we're suffering the most, more than any country is suffering from this virus. So I would like for you to elaborate on that, if you would.
Well, I think we have to basically sit back and look at this as a broader picture. We're in a war. We talk about the war on cancer. Everybody says, "Oh yes, we must eradicate cancer." Well, it turns out on a daily basis now that COVID-19 is the number one cause of death in America. It overwhelms cancer, overwhelms heart disease. So that we are in a war. And so if you're in a war and you're a soldier, you say, I don't want to wear the vest, the bulletproof vest. I'll take my chances. Saying, are you stupid or what? So we have to put this in more, I think, visceral terms that basically, put it, say, your future is going to be, you're highly dependent on how well you perform in this war. It's not going to go away. And even if COVID-19 basically is contained, there are plenty of other viruses out there waiting for the opportunity. to jump in and basically cause the same havoc. So we have to say this is a war not against a country; it's a war against an invader that has no political agenda. It says, "I'm here to basically kill." It does it very effectively if you're not prepared.
Okay.
All of a sudden, then it becomes more visceral, and people say, "I get it. I've got to basically do whatever I can to keep the enemy at bay. It's out there. Will always be there.
Mm-hmm.
And what can I do to minimize the likelihood of having enough of internal destruction that I have to go to a hospital? And once I'm in the hospital, it means that I've gone on a downward slope that I may not be coming out. So I think we have to make this more of a visceral aspect, just like World War II. It was saying we're in this together. We have one job to do, to defeat the enemy. And here it's not to defeat it, it's to control the enemy. But until we basically get that mindset, then people have their own agendas and will go on their own different ways, unfortunately.
Okay, great. Because I really do believe that it's going to be around a little longer than what we think. I think it's going to be something that we're going to have to deal with years to come. And it's you put it so blatantly. If we are in a war. It's actually a war, and so we're just going to have to find ways to continue to wash our hands, as everyone has made mention of that. Wash your hands like Grandma told you to, because I was raised by my grandmother too. Wash your hands. It's little small, simple steps that we have to take that is common sense. So with that being said, I would like to thank everyone for being on the panel. And I would like to go around the table, and we're going to start with Dr. Shapiro, where he can be able to also allow the audience to be able to follow him. Anything that he has upcoming as far as any classes or any books that he has released, he can be able to do that. Any social media links that he would like to share with the audience so they can be able to follow him later on, he can be able to do that at this time.
Thank you so much for the opportunity. It's a pleasure always to amplify the message. And I'm actually going to put my vaccine out there. And it's a vaccine that is very special, that I hope after this message and this communication that we're having between the four of us, people actually will take it. It's the vaccination against fear. It's the vaccination against that part of our brain that wants to hear and believe in stories that are not evidence-based. And you're actually not hearing for your brain or your heart. Then that's what I want everybody to get vaccinated after this conversation. It's okay to have a little bit of fear. It's okay to have doubts. It's not okay to reply and send and share, messages that are not true, or they sound kind of like pseudoscience, and just share it in social media or share it with other people. But it's amazingly okay to challenge the status quo and ask us, do I get this vaccine or that vaccine? Is this true? And that's why you have us to actually answer you that. And thank you so much for the opportunity. I can be reached on Instagram and Twitter at DR_Shaps, DR_Shaps, that's SHAPS. And also, I have, it's not a blog, but you can reach me at drshaps.com, and I'm here to help conversation, especially right now that we need to do a lot of engagement with our communities to get information out there regarding the vaccine.
Okay. Dr. Colbert?
As always, I appreciate this invitation. I think that you are a gift to your audience, providing a resource for credible physicians and medical experts to provide insight. I'm a huge advocate of patients. I'm a patient advocate. As an ER physician, I am a patient advocate. I am a huge, huge proponent of asking questions. And just as the other physician stated, it's totally acceptable, very human and honest to question and look at your audience that you're asking questions of. Look at the resources. If you have a problem with your car, you don't ask a plumber. If you have a problem with your kitchen sink, you don't ask an electrician. ask physicians, ask individuals who are understanding and can expand the conversation so that you can make an informed conversation, informed decision of your health. And that's what we should do as medical experts, is to provide insight for everyone to make informed decisions on their own health. And I hope I can be a part of that. I'm Dr. Christopher Colbert. I'm the APD at the University of Illinois at Chicago. Again, thank you so much for inviting me. My Instagram account is drchris.er. So it's drchris.er. You can follow the steps of what we do as a residency program, what we recommend, and what is recommended universally in reference to good health practices. Thank you for the invitation. I hope that your audience has taken away something positive and can utilize it in their life moving forward.
You're welcome. Go ahead, Dr. Sears.
Well, I too want to give my, again, a great thanks for inviting all of us on your show today, because this is how we get information across. If people would like more information about the nutritional aspects of addressing COVID-19, I recommend go to my website at drsears.com or my latest book called The Resolution Zone, and this is available on Amazon.com. But again, it goes back to saying that the victory over COVID will be in our hands, and really our will to fight this ongoing war.
Absolutely. So we have covered a lot today, ladies and gentlemen, on the podcast on today in regards to where is America in COVID-19. And so we thank you so much for following up with us as we continue to bring more information as to this topic as the situation continues to develop. So thank you, gentlemen, once again for being a guest on the show, and have a great day.